Welcome. I think folks are going to be trickling in, so we'll just get started. I know there's a hard stop at 1 o'clock. There's a keynote, so we want to get done way before that, go through questions and answers, and then leave the room. Very quickly, my name is Kumar Subramaniam. My colleague, Eileen Kazda, both of us have the Hopkins blood in us. And we worked at Hopkins for many years. We spun out from Hopkins as a startup because of the work that Eileen and her team did at Hopkins. And so what you will hear from us today is real-world experience of using AI to further safety management practices. This is not theory. This is not what if we did this or did that. We've done it. And we'd like to, in the spirit of a Congress, which is basically a group of people getting together talking about a topic, we'd like to present this information to all of us today. We're happy to answer questions, Eileen and I, after the presentation. So does all that sound good? So I apologize. The agenda slides looks much beefier than the content. Okay? So all in all, we have 12 slides. I'll cover 6. Eileen will cover the other 6, and we'll be ready to answer questions. But we wanted to take a moment to kind of walk you through this journey, which is what are the challenges we face as quality leaders? What are the limitations of current tools, if you will? We want to talk a little bit about the relationship and or the dichotomy between what we think are complicated systems and what we think are complex systems, and how we deal with each of those, and how we thought about it at Hopkins when we set about on this journey. Basically, complex, complicated leads to the problem of poor quality data, and we'll talk about how that kind of manifests itself in behaviors that you see in your organization. Then we'll quickly go into the section that Eileen is going to talk about, which is how do you improve the quality of data? How do you use AI as a co-pilot? So the theme of today's presentation is AI as a co-pilot. So the use of the word co-pilot basically says there is a pilot. And so you are all the pilots that a co-pilot is likely going to assist. So that's, if there's one thing that you need to take away from this is AI is a co-pilot sitting on the right-hand side of the cockpit doing things so that the pilot can fly the plane better. If that's an analogy you want to keep in your brains, fantastic. And then I'll let Eileen kind of speak to other details. But essentially, we want to kind of summarize your challenges. At least we think these are your challenges because we faced them at Hopkins. Groundhog Day, feeling like, oh, where have I seen this one happen before? Struggling for time, meaning to say all you have time in the world to do is handle sentinel events. You have no time to look at investigations. You have no time to look at near misses. You have no time to have similar events happen to us in the past. How do we address it? What happened to that action item? So all the higher order things, we have very little time to do. Then feeling blindsided is essentially not knowing what's happening as safety leaders across the institution. How do we address that? So our point here, I won't kind of read the slide to you, but the point here is all of these challenges leave us as safety and quality leaders anxious, worried, frustrated, all of the things that we bring to work every day. And imagine your staff coming to work every day, bringing these same sentiments with them, and then how do you get them to change how they think about safety and quality in the workplace? That goes to culture, that a whole host of other benefits accrue. And so before I exit the slide, the message here is, it's not that we aren't trying our best. It's not that we aren't committed. Nobody comes to work every day saying, let me see how I can mess this up today. They just don't, right? So that brings us up to this whole issue of what's the difference between a complicated system and a complex system, right? I won't speak to the slide again, but essentially, a complicated system is knowable. Aircraft engines are complicated, but they are knowable by experts. GE engines actually can track their engines no matter where they are in the world and track them to a point of failure because the system is knowable. But in healthcare, with so many experts spending so much time working with each other across departments, it's very difficult to actually pin down or predict what's going to happen tomorrow. And we pretend as though it can. And so because of that, we use tools that were basically meant for the complicated side of the picture and not for the complex side of the picture. That is the message of this slide. And so what we are trying to say and what we have experienced at Hopkins is that you're best served by observing, by tracking, by monitoring, and by using tools that help you collaborate better because it's impossible to know exactly what's going to happen. So how do you kind of react with that uncertainty is what we try to solve. So that's the message on this slide. And of course, the key problem with all that leads to is if you don't address the difference between complicated and complex, you end up with data quality problems. And when you end up with data quality problems, you create poor decision-making opportunities for yourselves. Not your fault. You're just dealing with bad data. So, poor visibility to risks comes right on top for any safety leader. This is the key thing that we noticed at Hopkins. We were so fed up and tired of being hindered on our HRO journey that we said enough. And we spent 3 years actually building this tool that we use at Hopkins today, 2018 to 21. We went live in April of 21, still going strong. And we've seen culture change at Hopkins because of simply by changing it. Now, they did a whole bunch of work on the top of all this. I'm not diminishing that. But everything needs to fit in, if you will. And then finally, we see system-wide dialogue happening at Hopkins around improvements that happen here, one location versus. So Hopkins is essentially 6 hospital system, 525 ambulatory centers, 6 ambulatory surgery centers, a home care group, and they all use the same exact mechanism to talk to each other. So on this slide, I'm going to have Eileen step in to talk about the 2 powerful ideas that we think are important to kind of communicate as a message today. So, Eileen.
Great. Thanks, Kumar. Can you guys hear me okay? Wonderful. So I'm going to pick up with kind of these 2 powerful ideas that we hope to leave you with. And when we think about both of these ideas, I think these both apply to leaders, staff, as well as patients. And then later I'll discuss some of the benefits and costs of moving to kind of this approach where we're using artificial intelligence and advanced analytics as a co-pilot for safety. But this first idea that we hope to leave you with is this idea that we can improve patient safety outcomes and work quality by improving the quality of data. And so when we think about our current environment, we know that we are inundated with challenges in collecting data. I think that a lot of our tools oversimplify the complexity of our healthcare systems. We often spend time kind of focusing on counting our problems versus really fixing those problems. Often our frontline staff will complain that they spend their time double documenting or that there's got to be more efficient ways to do things. And our leaders will often complain that they have incomplete information. And so I wanted to tell just a brief story. When I was working historically for Hopkins, I feel like I had kind of an aha moment. I stepped back one day and I looked at our resources for patient safety and I thought, 80% of my team's time goes into capturing data and manipulating data and trying to make sense of it. And only 20% of our time really goes into actually using that data and the insights that we derived from it to design safer systems. And I thought, wouldn't it be cool if we could somehow flip this equation so that 20% of our time went into getting the insights that we need and we could free our staff up, unlocking their capacity, so that 80% of their time went into the heavy lifting of fixing the broken systems that our staff are working in and that our patients are seeking care in. And so that kind of leads us to the second powerful idea, which is the idea of how can we improve resiliency and outcomes by using artificial intelligence and machine learning as co-pilots. And so we think that in order to do that, it kind of begs the question of how can we improve data quality. And so I want to share a couple examples of ways that we think we can improve data quality. And so the first one is really simplifying data capture. In healthcare, we're often really kind of focused on simplifying data, but if we can simplify this, we can also allow our staff to spend more time using the data, allowing people to work at the top of their skill sets, whether you're a frontline clinician providing care or you're a highly skilled analyst, doing the things that make the biggest difference. The second idea is really kind of recognizing and respecting that our healthcare systems are complex and complicated and actively evolving. I think if the pandemic taught us anything, we learned that staff are constantly changing, workflows are constantly changing, new technologies are constantly changing and entering our environments, and we need tools and analytics that help support the active evolution of our environments. And so the third idea is seeking real-time insights. I don't know about you guys, but so often I would see us take our data, we would export it to a popular data visualization tool, perhaps Tableau, Power BI, we'd look at all of these graphs, and we'd step back and we'd be like, now what? Because they weren't actionable. And so what we want to try and do is tease out the analytics that we have in a way that allows people to use this data more real time to drive meaningful change. And then kind of to that point, that really leads us to the idea that like richer insights might give us richer answers to problems, and that we can get to these answers quicker and take action sooner, ultimately preventing patient harm. So do we have any pilots in the room? Yes, one. All right. Well, I am not a pilot. I don't claim to be an aviation expert. But in my mind, when I think about what a co-pilot does in aviation, I think there's someone who really probably assists the pilot in keeping passengers safe. They're probably scanning for traffic. They're monitoring dashboards to surveil for risks. They're alerting the pilot or air traffic control when problems crop up. And so what would a safety co-pilot look like if we were to have someone kind of in our right-hand chair telling us where our risks are? Well, perhaps they're also monitoring safety data. They're keeping us updated about real-time risks and emerging risks, maybe even patients that need special attention. And then they're maybe even alerting us to similar problems across work areas, helping us prioritize our resources. And so that's the spirit in which we are thinking about artificial intelligence and advanced analytics being a co-pilot for patient safety and quality improvement. And so I want to share an example of, as Kumar said, we built a solution for Johns Hopkins, and in our event reporting solution, some of what we did is we went back to that 80-20 model that I was telling you about, and we said, all right, what would it look like if we could use artificial intelligence and advanced analytics to unlock staff capacity to do this? And so I'll share a couple examples of how we've done this in that tool at Hopkins. The first one is an example of tagging safety events. If anybody's seen a patient safety event report, you know that these are often paragraphs of free text narrative that staff type in, and it takes a lot of effort to read those events, theme them, and identify them. One way we've done this is we use an algorithm that reads that free text narrative to identify themes and send those themes out in real time to event reviewers. And we don't oversimplify. Instead of allowing many of the tools on the market, I think, allow you to categorize events by kind of one theme. Maybe it's a patient identification event, maybe it's a fall, but we know in reality these events are complex, right? They tend to happen in multiple areas with multiple problems in them. And so in our approach, we allow the tagging of these events to support the true complicatedness and complexity of the environments that we're working in. Another example of how we do this, and this might resonate with you guys, as a leader, I would often step back and I'd read events and I'd go, I wonder how often that's happening. Well, another way we can operationalize this is we can have algorithms that alert us to similar events so that the computers are helping us identify when similar things happen or when patients cross multiple events. A third example that might resonate with you guys, I would have to periodically go in and report to the board, what are our greatest risks to safety? And I would ask my staff, what are you guys seeing? And they would say, oh, here's some Post-it notes off my monitor. Here's some things we should work on. But we didn't have a systematic way of looking at the data and the problems. And so I think there's ways to use cluster analyses, and this is some of what we've been doing, to start to look at the trends in this data and alert us to them. And what we see is that our staff say things like, yep, I'm all over this problem, or they'll say things like, oh, this is a new trend. I hadn't seen this emerging. And so then they can start acting quicker. And then lastly, another example that we're doing is often when, as a leader, I step back and I say, like, okay, now I want to read what happened with that report. And it's pages and pages to read, and I just want the cliff notes. Tell me what we found, what happened, what did we do about it, and what are we doing to monitor for it? And so I think there's a huge opportunity in this space to use advanced analytics to make leaders' jobs more efficient as well. So as we expand our product portfolio and think about opportunities to improve safety, we think that there's ways to further integrate artificial intelligence as a co-pilot, not just in event reporting, but also in patient complaints and grievances, and also in tools like event investigation tools. And some ideas that we have around doing this are using artificial intelligence to help find hidden signals in data. We've already talked about how we know everyone is inundated with data, but how can we identify the patterns that are most important? And then two, simplifying the actions that users have to take with this. We can help see patterns that perhaps the human eye alone can't see and unearth these signals quicker. A third way that we can use these tools is to make organizations more efficient. I feel like often we want to throw more resources at the problems that we have, but I don't know how many of you are successful in getting resources, but it is really hard to get additional staff right now. So how can we free up our staff to use them in the most helpful ways? And then accelerating change, the idea of making sure that we're spending time on what matters most and putting the strongest strategies in place to really error-proof the healthcare systems that we're working in. I've spent a little bit of time telling you guys about the benefits. Hopefully I've sold you on some of them. There's definitely some risks that organizations run into, but often one of the questions we often get is about the costs. And people often talk about the cost of the technology alone or the cost of mitigating and migrating to tools. But the costs that I think that are actually greater here are the change management costs. And I think it's time that we start thinking about this a little bit more. Artificial intelligence and advanced analytics are here. But that also involves us changing the way that we work. It's not about thinking longer and harder, it's thinking differently in this space. We have to manage people's expectations of what technology and analytics can do. We have to start shifting the way we work. This may involve developing new workflows and processes or new procedures, modifying policies, things like that. So with that, we really wanted to leave some time to open this up for a discussion, but I wanted to summarize kind of what we talked about today. The idea that a co-pilot approach can improve the quality of data managed in safety and quality. We talked about how AI and ML can unlock staff capacity and effectiveness, and how real-time insights can lead to better decision-making and improved outcomes for both staff as well as patients, and how managing change is crucial for any of these programs to be successful. So with that, we're happy to take questions or comments, and we'll open it up. Sure.
So with the implementation, I mean, the machine learning AI is quite impressive in what it can do in connecting the dots.
Sure.
So with the implementation of your program, what have you seen in terms of clinical benefits that you can maybe share a story?
You want me to start? Sure. I'll start. I think the way I've thought about our solution for most of my time actually is that this is both a cultural and a technical intervention. And I think we see things that we can decrease the amount of time it takes to report, but we also see improvements in our ability to create follow-up to frontline staff. And then I think the more powerful stuff, though, is the perceptions of staff around how what we're doing actually makes a difference. I would say this is largely qualitative data, so as you can imagine, it's very hard to quantify the impact and the return on investment in some of these things, but the safety culture data has improved. We also see more engagement in areas that have historically not been involved or as involved in safety programs. Specifically, physicians are reporting more events. These tools are also being used more across the continuum of care, especially as we're bringing more care digitally, and so we have more engagement with users of these tools. Anything you want to add?
Yeah, the physician engagement jumped by 37%. Feedback to reporters jumped 165%. There's a whole host of metrics that you can talk to.
Yeah, I have to remind my team, though, that like capturing more doesn't necessarily make us safer unless we do something with it. And so what we worried about was we didn't want to just improve the experience for the front line. We actually wanted to do something that we knew would make a difference in safety. So we were trying to use the data and count the number of system changes that we've made as a result of events that have been reported.
So, I mean, we learned this morning, very difficult to quantify prevention, right? We learned it this morning.
Yes.
So did you see a change in patterns of things that popped up? Can you give examples?
Yeah, sure. So I may have, I don't know if this was a mistake in my career, but we implemented this during a pandemic. And I thought it was going to be challenging, but it actually wasn't. And so onboarding the software was easy, but our goal was not, a lot of people were like, did you increase the volume of reports? No, our goal actually wasn't to increase reporting. When we stepped back, we realized that while it's important to engage the frontline staff, our goal was actually to give the users of these tools. For example, at Hopkins, we get 120 events a day, and we have 2,500 reviewing managers who are routed these events. But those people didn't have tools to help them use the data in meaningful ways. And so what we went after was their experience and helping them with real-time insights and tools to actually take action on the data. And then the frontline stuff felt like downstream benefits of having focused on that.
Yes.
Just have a quick question regarding, was there any change in the reporting methods that clinicians use when you use AI? Because sometimes, to fill up that whole form takes a lot of time. And
Sure.
sometimes clinicians don't have the time, so they're under-reporting.
Yes, I've been a big proponent in my career of not asking for more things that I'm not doing anything with. And so we had already had fairly streamlined forms for data capture. The way our forms are set up, the frontline clinician, we have a quick launch from our medical record. And so when they're in the patient's chart, they can automatically import a safety event, and we pull all sorts of information behind the scenes around that patient and their specific encounter so that frontline don't have to fill that in. And then they just give us a free text summary of what happened, and we say we'll take it from there. They no longer code a harm score. They have locations and stuff that automatically populate, and it's very quick and efficient for the frontline to report.
Yeah, I mean, we all expect for our technology vendors to integrate with our solutions, right? We want them to integrate into our electronic medical record. We want them to do single sign-on, so you don't have to sign up again. We want them to know who we are, where we are, et cetera. So we've done all that. But we have applied all those things to make lives easier for our staff, right? So because we know who we are, we know where you work, we know that you have subscribed to these kinds of events, we can automatically route events to you. We do all the heavy lifting on our side. Sorry.
My apologies. Is there a way for frontline staff and management to kind of take the observability measures and traceability measures to understand where these analytics came from and go right down to the source so they can understand how your co-pilot becomes a form of redundancy for that?
Oh, that's a great question. Let me see if I can answer that. And of course, Eileen is the expert here. But when we design our machine learning algorithms, we are designing them based on the most current information that you carry in your systems. So what do I mean by that? We rely on a safety taxonomy that is co-created between the customer and us. In our case, we've done it twice at Hopkins. Once when we moved from multiple systems into one, and then when we moved from the one to the other, right, in 2021. And the first time we had to harmonize taxonomies across the 6 hospital systems and get agreement on what does this mean versus that mean. All that got sorted out. And then we had to go in and use our machine learning algorithms to train on that data so they could understand what were the cutoff scores at which point some team needed to be tagged to an event, or how many of those, right? So we talk about the sensitivity and the specificity metrics of our algorithms. And that was tested with persons who are safety experts who said, does this make sense to you? And then we also did something a little more, which is we made the machine algorithm such that it retrains every week. Now that may be different for you because people say, no, I don't like that. That really shouldn't be there. Let me add one more theme to this or remove that theme. And the machine learns. So over time, what it means is that it is adapting to your flexing organization. You may have added a new location, a new hospital, a new ambulatory clinic. It learns. You may have added a behavioral health unit somewhere. It learns. So I don't know if I answered your question, but that's what we are trying to do.
I just want to elaborate on that because I think this is always interesting when it comes up. And so one of the things that we learned in doing this is that, and you guys probably do this today, right? You spend all your time coding events and your staff probably say, well, that doesn't meet the definition. And when I look at our staff, half the time we didn't agree with each other in the same room anyway. So then what we did with our algorithms, and I think this is why this retraining is really important, because the definitions for these things are also constantly changing, and you're trying to use one code to maybe meet 3 reporting bodies. And so that's why we've set these up in a way that the models don't degrade over time, but they also stay relevant with the changing environments. And then I think the other aha moment for us is that kind of striking that balance between sensitivity and specificity was kind of key, because you could spend all of your time, again, coding for the definition and not actually fixing the problem embedded in the event report. And so what's good enough to unlock staff's capacity in order to use that data? And that's been a bit of a kind of an aha moment for us. And then the other thing that we've learned in this journey is that and these principles apply to all of our modules, not just our event reporting module, but the idea of what we think at the time of submission may not always be what happened after an investigation, and being able to have models that are thoughtful enough to accommodate both here's what we thought when it initially came in and here's what we learned as a result of the investigation.
Yes.
Reflecting on the keynote from this morning, so many of our safety tools are built in like a safety one paradigm, like something has already gone wrong. Do you see co-pilot tools emerging that are going to help us find the bright spots?
So the question is, can safety co-pilots help us predict the future?
Yeah, and learn from what went well, right?
Or
you want me to start?
Things are working well.
Yes, yeah.
And why they're working well.
Yeah, so we do some of that today. I think as part of our investigation, and really in the spirit of high reliability, right? We want to preserve what's working well while we're also designing against the flaws in our current systems. And so we do have some opportunities to capture what's working well as part of the investigations in our tools. We also ask staff up front, and this is kind of a no-brainer question, but one of my favorite questions when we ask our staff, what should we do to improve this? And often that gives us insight into how big a problem is, and we can integrate those learnings into our algorithms as well. So I still think there's huge opportunity here, but we're definitely thinking about that. We also use this to identify good catches or staff that perhaps have gone above and beyond in the spirit of maintaining safety and quality, and can feed that data to organizations for their staff recognition programs.
And before I come to you, the one thing that we will add is not much is said about near misses.
Yes,
right?
Good point.
And so things look like they work well. But what do the data say? Right? And using machine learning techniques and or AI to kind of pierce into and look into the gloom, if you will, to find out what the nuggets of information are, that's a good use of AI as well. Another good use of AI, if I may, is if any of you are implementing trigger tools can inundate you with data. Right? Not all of the data is a signal. A lot of it is noise. How can you use AI to sift through all the noise so you can get to the signal that your limited staff can work on? right? So that's another way we are thinking about machine learning and AI in this space. Yes, sorry.
My question, well, two questions. You had mentioned connection to EMR systems.
Ah.
Which EMRs is this, or is it any EMR? That's my first question.
So the question is, which EMR are we connected to? We connect natively into Epic today because it's the dominant EMR in the marketplace. And we have done something a little unique. We have written our own API that is deployed by Epic onto their infrastructure. So we're not going the ADT route where we are, again, swamped with information from Epic. That's one. Second?
So are you guys planning on doing any other EMR? That would be the second question. Well, that was a soft question to that.
We'll do Cerner at some point.
Yeah, Cerner is on our horizon as well, but for Cerner, the approach will be slightly different.
Yeah.
And then the second real question is, are you guys more focused on hospitals or are you focused on non-hospital settings?
We don't care.
We do it, all of the above. And actually part of our strategy, oops, sorry, you might be able to hear me. Part of our strategy is that more and more care tends to sometimes be provided in an enterprise environment. And so it's really cool when you can see the patient's journey across the enterprise in these tools. And so our tools can be used in ambulatory as well as hospital settings or connected enterprises.
Great. We are at 12:50. Thank you for taking the time. Appreciate you coming. And see you around.